So today I'm going to deal about thyroid cancer, as in what a surgeon will see once a patient with a thyroid swelling will come, and then how will the procedure be done, like what is the investigations, how do we suspect that there is something else. As we know, thyroid nodules are very common clinical problem. If you sit in an ENT OPD or an oncology OPD, once a week, at least 2 3 thyroid patients will be coming. So the problem is not only the benign thyroid glands, even differentiated thyroid cancer is becoming highly prevalent. Although it has a female predilection, the cancer as such is more rampant in males. Like any thyroid swelling in males would be more likely to be malignant compared to a thyroid swelling in the females. As you can see, patients will present to us with nodules like this involving the left lobe of thyroid or the right lobe or both lobes. So, ideally speaking, what are the things which we know can cause a thyroid swelling? It could be a benign, which is adenoma, or a colloid cyst, which are nothing to worry about unless they become big and require a surgical intervention. Then comes the inflammatory or infectious swellings in the thyroid, which could be thyroiditis, lymph, or tuberculosis. Yes, tuberculosis can occur even in the thyroid, and as it can occur anywhere in the body. And then comes the neoplastic nodules, which are either from the thyroid follicular origin, which could be a papillary carcinoma of thyroid or a follicular carcinoma of thyroid. Apart from that, the parafollicular cells are present just behind the thyroid nodules, which are required to produce the calcitonin. And a cancer in that origin of cells will form medullary carcinoma of thyroid, and the lymphoid origin will cause lymphomas. So the issue is that they have very similar presentation to benign. Benign and malignancy, they don't have very different presentation in the way that
Dr. Avinash, you're not audible.
both are having painless swelling, they will recommend. Hypo or hyperthyroid symptoms can occur in any patient, and pressure symptoms may or may not occur depending upon the size of the nodule. But what differentiates a benign from a benign thyroid from a thyroid malignancy, is that uh, the thyroid malignancy will be firm to hard in consistency when compared to a benign nodule, which will be generally cystic or firm in that way, less hard. Okay, neck nodes will be present only in case of carcinoma of the thyroid, as expected. If the patient is having neck nodes, it is more likely to be a malignancy. Then metastatic presentation, like sometimes the patient will present with a fracture limb or with lung nodules with breathing difficulty. Those situations, that is obvious to say that it is metastatic from the thyroid origin. If there is any recent history in the long standing swelling, recent history of increase in size, that is a benign swelling, a benign adenoma, which will generally progress and have malignant transformation and lead to an increase in size and the symptoms. Sometimes, very rarely, hoarseness can occur because of nerve involvement. It is quite late, and generally it is seen in anaplastic carcinoma or medullary carcinoma more likely. Usually, papillary and follicular cell carcinomas do not involve the nerve very easily. So, when a patient presents, what do we do? So, the first and foremost investigation is to do a thyroid profile and an ultrasound scan of the neck to know what we are dealing with. Rest follow after the initial these two investigations. We can further do the rest of the thing. I'll be going in detail about each of them. So why is thyroid profile important? Is because you have to know whether it is hypoeuthyroid or hyperthyroid. So in a hyperthyroid situation, one thing is that it is less likely to be malignancy, because generally hyperfunctioning nodules are not malignant in a general way. There are always exceptions. Uh, Also, you should not poke a needle into a hyperthyroid patient in general, because it will cause bleeding and cause hematomas and sudden increase in size of the swellings and all that. So you can wait for the patient to become euthyroid, or at least symptomatically less hyperthyroid, and then go for FNAC. Hypo and euthyroid, you can proceed for FNAC and then go ahead with the whatever procedure that has to be done. Okay. So as per the ATA guidelines, that is the American Thyroid Association guidelines, the serum TSH should be the first initial evaluation of the patient. And also, if it is subnormal, then you have to do a iodine scan. That is, if it is hyperthyroid, then you have to do iodine scan, so that you get to know whether it is a hyperfunctioning nodule or a diffuse hyperfunctioning, which is going to change your management. So the next investigation that comes is the ultrasound scan of the neck. So the thyroid, so as per the ATA guidelines again, you have to do in all cases when you're suspecting any thyroid nodules, so that you can get to know precisely what you are dealing with. So you have an option of differentiating between benign and malignant nodules based on the uh, USG findings. You have to use a high frequency probes. It can also detect nodules which are not palpable to us, and also detect nodes which are present in the neck. And also a guided FNAC is going to be much more specific and sensitive in case of dealing with thyroid malignancy. So to differentiate and to generalize standardize the reporting of the USG of the neck, we have something called a Thyroid's classification, in which we have to see few factors which are going to determine whether it is a malignancy or a benign nature of the disease. So we have to see whether it is cystic or solid in consistency, whether it is hyperechoic or hypoechoic, and whether the shape is tall or wide. Depending on that, you can also change the guide, or it will guide us where to proceed with the further investigations, whether the margins are smooth or whether they are lobulated, irregular, whether there's an extrathyroidal extension. So, and then also you have to see the microcalcifications. So based on all this, you are more likely to know that solid components in a uh, solid nodules are more likely to be malignant. Hypoechoic nodules are more likely to be malignant. Taller and wider are more likely to be malignant. And also extrathyroidal extension and irregular margins are likely to be malignant. And also, if you see microcalcifications and punctate foci, they are more likely to be malignant. Having dense macrocalcifications are generally benign. So based on this, everything is given a point, and then you have tirads 1 to 5, in which 5 is the most suspicious and 1 is mainly benign. So as I was telling you previously, in hyperthyroid state, you have to do iodine scintigraphy first. Initially, in previous days, a routine iodine or technetium scintigraphy was done in all cases. But now we have limited the use of iodine scan preoperatively only in case of hyperthyroid nodules, because that way, if it is a diffuse uptake, as in the first picture, then you have to go by medical line of management, and surgery is advised only in case medical management is insufficient or it fails. If it is a focal uptake of the iodine, radioactive iodine, then it will show that removal of that nodule is sufficient for us to go for the treatment. So surgical treatment would be preferred in case there is a focal uptake, right? So then the next thing and the most important thing for us to go ahead is a FNAC. So FNAC will guide the surgery. It will help us if we know preoperatively that it is cancer or it is benign, we can counsel the patients better. So we have to make sure that we are taking the FNAC from just the solid component of the tumor. So based on the FNAC, it is again standardized for reporting as Bethesda 1 to 6, in which 1 is non-diagnostic or unsatisfactory. Sometimes when you poke a needle, only blood comes or only normal fluid comes and you're not able to get any follicular cells. So you can't say whether it is malignancy or no malignancy. So you categorize it as Bethesda 1. When you see that it is a typical benign follicular lesion, you can give it as Bethesda 2. Bethesda 6, that is totally sure that it is malignancy and you have to go for total thyroidectomy as a treatment of choice. Suspicious of malignancy is given when there are some features which are suggestive of malignancy, but it may or may not be a follicular cell origin malignancy. So Bethesda 6 is basically going to be a papillary carcinoma of thyroid or follicular carcinoma of thyroid. But Bethesda 5 is suspicious for malignancy, your lymphoma, your other tumors of the thyroid, they will all be classified as Bethesda 5. And Bethesda 3 and 4 are suspicious. Even adenomas and follicular adenomas can also be classified as Bethesda 4 on FNAC, because the only differentiating factor between a benign follicular adenoma and a follicular carcinoma is the involvement of the vessels or the capsule, which cannot be determined on the FNAC.